added to YouTube. Just FYI.
Okay.
So that you're aware of that. I always like to just let you know that that's what's going on. Just so it's not a big shocker that I'm doing it. Okay, so now we're back. So what are the signs and symptoms of GERD?
You've got chest pain, and
how is that pain exaggerated? So you have chest pain.
Well, it gets worse when you lay down, and it gets worse 30 to 60 minutes after you eat.
Okay, so that's a pretty good general overview. Now here's the exact stuff that I pulled from the notes. So weak esophageal sphincter allows gastric juices to be released back into the esophagus during digestion. This causes scarring of the esophagus. Many patients self-medicate to relieve heartburn associated with this disease, but is only a temporary fix. If this practice is continued, patient will develop electrolyte imbalances. Okay, so milk of magnesia, Tums, those are all magnesium, calcium, and potassium based. So they're going to keep taking that stuff, and it's going to drive those up with the associated negative consequences.
Yeah.
Okay. Signs and symptoms: pain's worse when you lay down. Elevate head during sleep. Pain mimics heart disease. And what's the red line say about heart disease?
You have the. I knew. What does
look at the notes. Look on the paper number 3. The red stuff underlined on the computer.
Oh, okay. Hang on.
If I ask something like that, it's usually on the screen for you. So on the right side, look under signs and symptoms number 3. It says pain mimics heart attack, and there's a red thing underneath it, underlined.
I'm having a hard time pulling it up.
Okay. Is it not on your screen?
Well, it's on my phone, but it's so tiny.
Oh, okay. On your phone. I thought you were on a computer. No problem.
No.
Okay. Well, if it's that small, I'll just help you for the sake of time. I'll help you. It just says to teach patients to assume it's always a heart attack and to get emergency care until it's ruled out by a medical professional. Don't let them assume it's heartburn. It's a heart attack.
Right.
Okay. Respiratory signs and symptoms can develop due to esophageal damage. So they can get difficulty breathing, dyspnea, they can start to get gastric backflow back in their lungs. Different things can happen.
Yeah.
Okay, so we're going to keep going. So here we go. So GERD risk factors. So risk factors for GERD, do you remember what they were? There's 4 of them. Or there's 8 of them.
Is it genetic?
Genetic is definitely one of the components, but obesity. If you hear me say fat camp, I'm saying obese. I mean obesity. That's what I'm saying.
I knew what you were meaning. I just think it's funny.
Okay, obesity.
Okay, so how about smoking and alcohol?
Hey, those are 2 that are in there. So smoking and alcohol are 2. Obesity, the parasite that women go through to procreate. What's the parasite called?
When they're pregnant.
Pregnancy is one of them. Smoking and alcohol. One that we did talk about in class yesterday is hiatal hernia.
Oh, I would have forgotten that.
Hey, so can you tell me what a hiatal hernia is since you've forgotten it? Now that you've heard the phrase.
Hiatal hernia is right at the top of the stomach, but below the sphincter, right?
So yeah, it's actually the cardiac sphincter of the stomach has done what?
It's loosened. It's bulging.
Yeah, normally that sphincter is located right in line with the diaphragm. But when a hiatal hernia develops, where does that sphincter move to? Above the diaphragm or below the diaphragm? Above. It moves closer to your mouth, so it transcends and moves up the diaphragm. It moves past the diaphragm closer to the mouth, and so the sphincter and a bulge of the stomach is actually above the diaphragm. Okay, so you're good. That's awesome. Okay, fatty foods.
Yes, fatty food.
Part 2. And then chocolate.
Why chocolate? Did they ever explain that in class?
She never explained it. I didn't ask. It's just and I would imagine that chocolate again falls into the category of fatty foods. And I think honestly, this is my personal opinion. I haven't looked this up. I think it has to do with the digestion of fat and the digestion of chocolate and sweets and how they're digested. Mm-hmm. And they would aggravate GERD and whatnot. So just avoid, if you're getting GERD symptoms, avoid those things and you'll be good. Okay. So what's the prescription? How do we treat this? There are 2 main types of treatment.
There's surgery.
Okay, and surgery would be considered number 2, which is invasive, right? What are the non-invasive ways do you think we can treat this?
Changing your diet.
Yeah, so changing diet, right? Anti-acid.
What kind of foods are you gonna eat instead to help this?
So yeah, I'm gonna click over to the slide and just go to the answers. So here are the actual answers from the notes. Okay. So acid suppressing meds, stop smoking or getting secondhand smoke. So if you're receiving secondhand smoke, get away from that. Stop, stop caffeine intake, check for a gluten allergy, get a high protein diet, sleep with your head elevated, and to elevate your head 2 to 3 hours after meals.
Yeah.
Okay. And then you already got the invasive one, right?
Yep.
And then the blue line at the bottom is just a reminder. Okay. The prescription that we give to people in the ER to rule out if it's cardiac or if it's gastric is to give them what's called a cardiac cocktail, which is a laryngeal numbing agent, and it's an antacid. If the pain is relieved with that, it's gastric. If the pain is not relieved with the cocktail, then it's cardiac, and they'll treat it as a heart attack.
That makes sense.
Which, yeah, totally makes sense when you hear it.
But why do they do that cocktail? Because Megan made it sound like they just immediately run the cardiac tests. They can't wait for the cocktail to be done.
Well, again, so I mean, think about an ER, right? So somebody comes in complaining of chest pain. Okay, first thing they're going to do is put them on high flow oxygen and check their airway to make sure, and then auscultate their lung sounds to make sure there's no pulmonary edema, because even this will give some of those symptoms. So they check all that, and then they put them on a 12 lead, and they look at their cardiac rhythm right there. As soon as you put them on a 12 lead, are you going to know if they're having an MI right there?
I don't think so. You might see some symptoms.
If they have an altered cardiac rhythm from an EKG, they're having.
As long as it's not from a previous heart attack from damaged cells.
Yeah, well, and again, you're going to ask those questions as you're doing all this. Hey, have you had a previous cardiac incident? What was it? Oh, I get angina. Once every 6 months, my doctor gives me oral nitro, sublingual nitro, and that relieves it. Right. So you're going to start to, again, so what I'm saying is you're going to develop this with the patient. If they come in clutching their chest saying, I'm going to die, and I feel like my heart's exploding, that's a clear verbal indication that they've transcended GERD and gone to MI. You know what I mean? Again, one of the widow makers is when someone tells you they feel like they're going to die, believe them. Believe them. Most people with GERD will say they're in pain, but they probably aren't going to say they're going to die.
Right.
So again, that's what they're paying us the big money to learn to do right now, is to be able to discriminate and say, hey, the way this patient presents, I'm leaning more towards cardiac. I'm still going to follow my procedures and rule that out by doing EKG, checking pulse ox, checking pulse, doing those tests. Then I'm going to make a decision. But at the same time, I can certainly give the cocktail. And what do you think happens to people in pain if it's GERD related? If you give them that cardiac cocktail and they start getting some relief from that GERD, what do you think happens to their blood pressure?
It's going to drop.
It's going to go down, right? Because they're not in stress anymore. The stress response is down because, hey, man, I feel better. I'm at the hospital with a nurse who cares about me, who's helping me to feel better. And so their stress levels drop, and we're going to see a definite drop in their pulse and blood pressure, which is awesome when that happens.
Yeah.
Because it means we're hitting it. But if we give them the cardiac cocktail and we're seeing EKG symptoms, their pulse ox is down, we're giving them high flow oxygen, and we're not getting the responses, guess what? They're having a heart attack. That would suck. Okay. So hiatal hernia, you kind of already talked about it. Okay, this is page 2 of the notes. If you're following actual notes, I'll tell you where we're at.
Yeah, I'm not looking. I'm cooking dinner, and then I'm gonna have to deliver it. So
that's fine. We'll just keep going.
So I might have to cut out early, but
that's fine. We'll just go as long as you can.
Yeah.
Okay, so hiatal hernia, we talked about it. What's the pathology? What's happening in the body that's causing this?
Okay, so it's a bulge. The cardiac sphincter, is that what you called it?
Yeah, the cardiac sphincter is the one at the top of the stomach. I don't know. I think it's called the esophageal sphincter. Okay. I know the older version, which is cardiac sphincter, and it's called cardiac because it sits right behind the heart.
Right. So that sphincter bulges up above where it should be.
Yeah, it passes through the diaphragm and now is sitting closer to the mouth, and it's sitting above the diaphragm, and it causes that sphincter to even become weaker. If it was already GERD and it was already leaking juices back into the upper respiratory esophageal area, it's now going to be even less able to do that because it's lost the strength of the diaphragm. In addition, that and they get a herniated piece of the stomach above as well. It's probably holding gastric juices up there.
Yeah.
So it basically makes it worse. Okay. Risk factors for this. Let's go through them. They're very similar to the first one.
Okay. Is this one genetic as well?
So this one here doesn't have a genetic component either. It just says, so the ones that are the same as GERD are pregnancy.
Smoking and alcohol, pregnancy.
Yeah, pregnancy and obesity, fat camp.
Obesity.
Okay, the different ones, smoking and alcohol are still there. Those 4 are there. Pregnancy, obesity, alcohol, and tobacco use is still there. The ones that are different, now this one has an age component to it. Okay?
Oh.
This one has an eating disorder component specifically dealing with bulimia, where chronic vomiting is the issue. And then weight training. Those who do a lot of high-level weight training.
Yes.
Okay. So what were the ones that were the same? Name the 4 that were the same.
Okay. The ones that are the same are smoking, alcohol, obesity, pregnancy. And then the ones that are different are weight training and age. What was the age?
The age is hiatal hernias are very common and occur often in people over 50 years of age.
Okay. So age, weight training, bulimia.
So just state eating disorders, dealing with vomiting. Habitual vomiting is really what they're talking about.
And you listed one more, and I can't remember it.
No, you got them all. Age, pregnancy, obesity, habitual vomiting, weight training, smoking, and alcohol. And then the age is over 50.
Awesome.
Which one is missing, though, this one? Which one's missing? Gender. It's not gender specific. There's not a gender component to this one.
Was there a gender component to GERD?
No, there wasn't a gender component in that one either. In the major risk factors that we saw, there wasn't a major genetic component, or major genetic or gender component.
Okay. Cool.
So signs and symptoms of hiatal hernias. Okay. Again, this one has a really funny one because it rarely causes signs and symptoms and is usually found. The doctor usually finds this because of what previous disease process?
I can't remember, but I do remember that there were no signs and symptoms.
Yeah, GERD's happening. So they're complaining of GERD symptoms. The doc goes and scopes them, and then, oh, hey, by the way, you have a hiatal hernia, which is exacerbating your GERD. It's a double whammy, right? It's a death spiral. They had a hernia. Now they're getting GERD symptoms. We all look at hiatal hernia, scope them, or we X-ray, and bam, we see the hiatal hernia. I'll the doctor go in and fix that.
Yeah.
Okay. So again, just as in hiatal hernia, just as in GERD, a hiatal hernia can mimic what? What can it mimic?
It can mimic myocardial infarction.
Yeah, just it can mimic cardiac problems, and so we always tell patients if you get chest pain, assume it is a
heart attack.
Heart attack, and get help. Do not wait. You'd rather hear, "Hey, you just drank too many Pepsis and you get yourself heartburn," than, "Hey, you had a heart attack and died, and now we got to tell your family that you thought it was heartburn."
Yeah.
Okay, so again, the prescription of treatment for this is acid suppression medications, surgery if it's severe enough, okay? And the surgery is this laparoscopic. They pull the stomach up, they wrap it around the esophagus, and they tie it off, and then they drop it back below the diaphragm and stuff. And there are some side effects to that. I'm not going to get into those right now, but there are some side effects that we'll talk about on like a different day.
Okay.
Okay. The next disease process is peptic ulcers.
Yay!
Can you tell me what a peptic ulcer is?
A peptic ulcer. No, I forgot this one. I blame.
So this one. So now we've left the esophagus, and now we're dealing just straight with the stomach.
Okay. So this is just an ulcer in the lining of the stomach.
Yeah, it's a deterioration of the
result
lining
in perforation, or it could not.
Yep, it's just a deterioration of the lining of the stomach, and there's different severities. What causes the deterioration of the stomach?
It happens. Why does it happen?
Is it too much crappy food, or is it because I got nasty bacteria?
It's bacteria.
Yep, it's H. pylori or Helicobacter pylori. H. pylori is the bacterial name.
Yes.
And if you want an interesting read, look up how that was found out.
Oh.
I won't tell you how that was found out, but it's actually really funny how we found that out. That H. pylori is what's causing that.
Okay.
I won't cheat you out of a chance to look that up for yourself because it's actually a really cool story.
Okay.
But next time I talk to you, I'm going to ask you about it. I expect you to tell me. Because I'm mean.
Okay.
I told you up front I was a little bit mean, right? I'm a little bit of a teacher. I'm going to be mean.
Yep.
Okay.
What you have to do.
Yep. Okay. So I'm going to read this so we get this really well. It says erosion of the stomach lining. The bacteria of H. pylori are present in more than 90% of the duodenal ulcers and about 80% of the stomach ulcers. Stress ulcers are common in hospitalized patients. Okay, so stress induced. Why would a patient in a hospital who's receiving care get a stress ulcer?
Hospitals are stressful.
Yeah, they're in there because they feel like crap, right?
So a peptic ulcer is a stress ulcer. Those are the same.
Yeah, there's a spectrum of what they are, right? There's a spectrum of what they are. And they're traditionally, all peptic ulcers are traditionally associated with stress and poor diet, but we've learned that H. pylori is the major indicator. And then that is exacerbated or made worse when we have stress, we have a reduced immune response, and then it starts to attack the lining of our stomach, and then it just makes it worse.
Yeah.
Okay. Okay. So they develop due to burns, head injury, and critically ill patients. Okay. Multifactorial causes, but shock is known to cause low blood perfusion to the stomach. So we know that perfusion to the stomach can really affect this. Okay. Treated with protein pump inhibitor drugs, i.e. pantoprazole, or the street name Protonics. So remember, the last 5 letters or 4 letters, Z-O-L-E, Zol, is the kinds of medication they give for this.
Okay.
Okay. So what are the risk factors?
Risk factors are hospital stay, bacteria. What else?
Okay. So again, obviously smoking and alcohol are big ones. NSAIDs is a new one. What's NSAIDs? What's that?
We've got medicine. So
yep.
aspirin.
Aspirin?
No, aspirin is different than an NSAID, isn't it?
It is, but it's considered part of the NSAID class for the sake of this class because it does irritate the stomach.
Okay.
So non-steroidal anti-inflammatory drugs is what NSAID stands for. Aspirin, ibuprofen, and naproxen are the major ones that are considered part of this class.
Because what those do is dry up the mucal production, which is what protects the stomach lining.
You totally nailed it. Perfect. Okay, tests for peptic ulcer disease and upper GI bleeds. Okay, tests for these that we test for is a CBC count. So let's do a little bit of test question wargaming here. How would a CBC test be used to check what would a CBC look like if we had an upper GI bleed?
Okay, so you're gonna have a upper GI bleed, CBC count. You're gonna have a low hemoglobin and hematocrit, right?
Yep. So, and those two fall into what category of blood type? There are 3 of them: red blood cell, white blood cell, and platelet.
Yeah, those are red blood cells.
Those are red blood cell components, correct. So if we see an altered hematocrit and hemoglobin, if we're bleeding, are those going to be high or are they going to be low?
Those are going to be low because the blood is escaping out of the bloodstream.
Awesome, you got it. Okay, esophagogastroduodenal scope. What's an esophagogastroduodenal scope? What is that?
So that's how it's like a little video that they stick down your throat to see what's going on.
Yep. They physically inspect using a camera. That's really all that means. Yep. So they go in the mouth and they keep going until they come out the butt. No, I'm just teasing. They don't go that far. I mean, I guess technically if the scope was long enough, they could, and they could visually inspect the whole GI tract. But in this case, it's the esophagus.
What does duodenal mean, though?
Remember from our anatomy class, the duodenal region of the small intestine is the top 6 to 8 inches of the small intestine.
Yeah, got it.
See, this is the kind of stuff that's nice in study group that we can do, because you can ask that question here, but Megan doesn't have the time in class to ask that, and you feel like a dum-dum asking it.
Right.
Right. I mean, even I feel stupid sometimes asking stuff that I should know. But she's going pretty fast. She's pacing pretty hard. And that's what's great about study group. You can slow down. And whether I know the answer or another member of the study group knows the answer, somebody knows the answer, or we all collectively just say, we don't know, let's go look it up.
Right.
And sometimes we do that in the study group, and sometimes we just move on and we go and we come back at the next study group and talk about it. We make like for example, I told you to go look up H. pylori and figure out why that's important for peptic ulcers, because the story is actually pretty cool.
Yeah.
So we'll keep going, okay? So let's just keep going. So biopsy of stomach tissue. What's a biopsy?
When you actually take a sample.
Yeah, you take a sample of the tissue and check it for whatever's going on, whether it's cancerous, whether it's just damaged, precancerous growth, you know, it's metaplasia, whatever's going on, that's what you're doing that for. Okay, H. pylori blood test. That's pretty straightforward. You're just looking for H. pylori bacterial cells in the blood. And then occult blood smear. What's an occult blood smear?
You're looking for hidden blood, not visible, but it's still there, and the smear is the poop smear.
Yeah, it's the poop smear. You're pooping it, and then you're testing it because, again, if it's invisible or occult, you have to use that chemical to bring out that the red blood cells are present.
Yeah.
Okay, awesome. Prescriptions, what we do to treat this: combination of drug therapy, antibiotics to kill H. pylori, along with an acid-suppressing medication, usually will cure this. It relieves the symptomology, it removes the bacteria, and what's really
stopping NSAIDs, right? I mean, you have to.
Well, yeah, you take NSAIDs out too. You basically remove the offending agent, and then you give the antibiotics to kill the bacteria. And then you know what? The stomach is awesome because it really, really wants to heal itself. It's a very, very strong organ for that, and so we see a really, really good cure rate on this.
Cool.
Okay, here we go. So the next piece is, and I'm not going to hit this as much, but the different types of ulcers, there's 3 kinds: duodenal, gastric, and stress. Okay, so on page number 3 of the notes, and I'm not going to spend too much time. I'm just going to say that in my notes, you'll notice I built the spreadsheet, but it's blank. So we're going to go through this together as a group, and we're going to start covering down on this.
Okay.
Okay, so in the sake of time, because it's already 15 to the hour and you want to go deliver soup or whatever you're doing, but we're just going to keep going. Just be aware. So the 3 types of ulcers are duodenal, gastric, and stress. The components that we're going to be looking at are age, gender, stress factor related, hyperacidity, which means elevated acid in the stomach, urogenetic drugs, associated gastritis or inflammation of the gastric system, bacterial infections, pain, and then hemorrhaging. Okay, and how they're associated. Okay.
Yeah.
So signs of a GI bleed. I mean, obviously you're going to have blood and stuff. Okay.
Yeah.
There's occult GI bleeding and overt GI bleeding. What's the difference?
Overt, well, hidden versus obviously bleeding.
Yeah. So occult is hidden. Overt is definitely something you can just physically see it.
Okay.
Then we had hemoptysis or hemoptysis.
Bloody vomit?
Yeah, bloody vomit, okay. Bright red emesis is very dangerous, but coffee ground emesis is not as dangerous. Why? What's the difference?
Fresh. How far away from the bleed are you? Has it been digested?
Yep. If it's bright red, it's near the top of your esophagus, which is closer to associated critical structures, as opposed to blood that's ripped from the esophagus and it's drained into the stomach. It started to be digested, and then you vomit it up.
That makes sense.
Okay.
So wait though. Is it just more dangerous because it's bright red and that means it's happening right now and it's fresh, or is it, like you said, the location of it indicates that it's a more dangerous area?
Can I give you an example? And then you can tell me why it's different. Okay, I have a GI bleed that's bleeding slow enough that I'm not immediately throwing it up. It's draining into my stomach and it's building up in there. So it's building up and it's getting digested, and then I'm throwing it all up later. Or I have a fairly significant GI bleed right next to my esophagus and trachea opening. If I have a GI bleed bad enough that it's up that high by the break between my windpipe and my trach and my esophagus, could that occlude my airway? Could I start having breathing difficulties?
Gotcha. Yeah.
That is the difference. Okay. Let me use a good example though that you'll appreciate. So my dad, about, I want to say 15 years ago, he did not have a heart attack, but he had some heart issues. He went into the hospital and they put some cardiac stents in his heart to open up some of his cardiac arteries. His heart arteries. Right. They missed with one of them and it nicked part of his esophagus. That blood started bleeding into my dad's stomach. So my dad was in the hospital and he ended up throwing up 2 liters of coffee ground blood from his stomach. Would that still be a life-threatening condition? Listen to the volume that he threw up. He threw up 2 liters of GI blood.
That seems life-threatening to me, is it not? Because it's coffee ground?
That is really life-threatening. Even though that blood had been in the stomach a long time and been coffee ground and started getting digested, you only have 7 liters of blood in your whole body. And oh, by the way, my dad just had a cardiac surgery.
Right.
So he's reduced his blood levels. He's puked all that out. He's damaged his esophagus, and he's got stomach digestion of blood. So he had 3 or 4 different disease processes that were very serious.
Wow.
He lived.
I'm assuming he made it out okay because telling the story.
My dad walked in to the hospital that day and had run a marathon 3 days before that.
Oh my gosh.
So you can imagine he was in pretty good shape. And so that's what saved his life. My dad probably weighed about 190 pounds. He was probably somewhere in the neighborhood of 18 to 12% body fat. And the guy ran 70 miles a week.
Wow.
So yeah, he was definitely not. Yeah. My dad's a tank. He still runs like that. He's like 80 years old.
That's amazing.
Okay. Melina. What's Melina? And that's not somebody's name.
I forgot what Melina is.
Melina is black sticky stool.
Oh, and it's stinky.
It smells bad. And that's Melina is usually blood that's in the small intestine, large intestine. It has a time to get partially digested and get that odor, and it gets worked over. As opposed to hematoschizia.
Hematoschizia.
Pink hemorrhoid blood.
Oh.
So hematoschizia is bright red blood coming from the rectum, and it's usually associated with hemorrhoids.
Okay.
And it's not life-threatening at all. It just means that they're getting hemorrhoid rupture, or they're getting compacted fecal matter passing over those hemorrhoidal polyps, those hemorrhoidal bumps. It's causing the epithelial layer, skin layer to be scraped away, and it's causing some bleeding.
But this is the one she said that people would think that it was life-threatening.
Yeah, they freak out because they see blood in the toilet when they're done, and that's really scary.
Yeah.
Okay. So there you go. So let's keep going. So now we're on page number 4. Irritable bowel. What's irritable bowel?
I think I need to go now to drop this food off.
Man, no, I'm teasing. You don't suck. Okay. We've been going for about 40 minutes, and we've gone through 4 pages.
Man.
That's okay. No, I'm just letting you know kind of pace. Feel the pace. So the more prepared you are, the better it will work.
Gotcha. Okay.
But you got through 4 more pages today than you did before. You would have normally gotten through.
And you're doing one tonight again?
At 9:30. Yeah, I'll be back on at 9:30.
Okay, I'll be more prepared.
Yeah, you're no. Yeah, well, I mean, just again, this is a study group. This is not required. I want you to enjoy this, but just understand that again, we help each other. I'm going to drive the train either way.
Yeah.
But again, the more prepared you are,
I really appreciate it.
You're fine.
Great momentum, and thank you so much for doing it.
Okay, you're awesome.
Okay, thanks a lot, Chris.
Keep it real.
See you
bye.
tonight.
Okay, bye.
Bye.